This is Have You Met? My guest today is a renowned consultant neurologist, sleep physician and author. He's mostly known for his two books, The Nocturnal Brain and The Secret World of Sleep. In this conversation we talk about common and extreme sleep disorders, why it's important to get a good sleep, and how to actually try and do that. Have you met Guy Leschziner? So, Guy, tell me exactly what is a neurologist and how did you become one?
Wow, that's a good opening question. So what is it? What is a neurologist? A neurologist is a doctor, a physician, who is involved in managing any area of health related to the brain, the spine, the nerves, or the muscles. Muscles are viewed as part of the nervous system from a clinical perspective.
Okay.
Now, the range of the kinds of conditions that we see is enormous. It can be something incredibly acute like stroke or meningitis or seizures, to chronic conditions like Parkinson's disease or Alzheimer's disease or genetic conditions of the muscle. So we tend to have, within the practice of neurology, we tend to have our own little area of subspecialty expertise.
Yeah, that's amazing. So how did you get into it? How did your journey begin? Let's go back right to the start. When did you first become, I don't want to say obsessed, but interested in the brain and how all that works specifically?
Well, I remember even before going to university, I was always interested in how the brain worked, and was particularly swayed by reading certain books, books like The Man Who Mistook His Wife for a Hat, which is Oliver Sacks's most famous book, which really outlines a series of patients of his, of interesting cases that really give some extraordinary insights into the workings of the human brain. And so even before I went to university, I knew that I was interested in neuroscience, and in fact applied somewhere where they had a particular interest in neurology and neuroscience. And so I was very focused, even from a very early age, on neurology as the specialty that I wanted to pursue. And when I got to actually practice it, realized that it was as interesting, if not more interesting, than I'd appreciated.
Yeah.
And so that was really the start of the journey.
Wow. Yeah, I bet it's like a kind of Pandora's box, the brain and neurology. It's just endless surprises, I imagine, for you.
Well, from a doctor's perspective, one of the fascinating things about neurology is that it really encompasses every aspect of our lives. So although, when you think about it, it makes absolute sense, on a day-to-day level, you don't think that the nervous system controls, for example, your gut. It doesn't control your bladder. It doesn't control your personality. It doesn't control, whether or not you sweat, even, really, really basic things. But of course, the nervous system is responsible for all of that. And so neurology really is the one specialty that seems to tie together everything else.
Yeah, all encompassing. So where did you go to university?
So I did my preclinical in Oxford, and then I did my clinical studies in London at Imperial.
Yeah. And was that all neurology specific studies, or is it you start off doing medicine in general and then?
Yeah, so I started off doing a medical degree, as did everybody who is now practicing as a doctor. And then once you start working, then that's when you start specializing. And then halfway through my specialty training, I then did a PhD, which was split between Imperial and Cambridge, and then came back to finish my clinical training.
Okay, cool. And then you went straight into it, and you kind of had the opportunity early on to get into specifics on the brain, into neurology.
Yeah, so I worked as a junior doctor, as a house officer for a year, and then did 2 years as a senior house officer, which is the next grade up. And within the senior house officer rotation that I did, I had chosen to do a rotation that encompassed neurology, really just to reinforce in my mind that that's what I wanted to do.
Yeah.
And it was at that time that I then chose to go off and do a PhD. And my PhD was as part of the Human Genome Project in Cambridge, looking at genes that influenced whether or not you develop epilepsy and how you respond to particular drugs. And then I came back and finished my training in London and the Southeast before taking up a consultant post.
Wow. Cool. You mentioned epilepsy.
Yeah.
What exactly? I mean, obviously everybody knows a little bit about it, right? They know it comes with seizures and things like that. Tell me more. Tell me exactly what is epilepsy.
Well, epilepsy really, at the core of it, defines a predisposition to seizures. That's all it means.
Right.
And um, but we know that there are many different diseases of the brain that can predispose to seizures. Some of those are genetic, others are related to, for example, tumors or stroke or head injury. Um, the causes of epilepsy are huge and variable. The other thing that people fail to appreciate is that everybody thinks of seizures as being large convulsions. So the
Yeah.
typical picture of a seizure is somebody who collapses to the ground, frothing at the mouth, violently shaking, and then being unconscious for a prolonged period of time afterwards. Yes, of course, that is a seizure, but there are a huge array of different types of seizures, and these relate to where in the brain the abnormal electrical activity that characterizes a seizure originates and how far through the brain it spreads. So, common types of seizure that don't represent these generalized convulsions are seizures arising, for example, in the temporal lobe, which is the seat of our memory. And people
Right.
will often, for example, experience a strong sense of deja vu and become a little bit confused afterwards. And that can represent a seizure. I've got individuals, patients who I look after who, for example, when they have a seizure, see visual hallucinations because the seizure is arising in the visual part of their brain.
Wow.
And if, for example, the seizure arises in the part of the brain that represents where you are in space, a three-dimensional representation of your body in space, then that can result in some very odd seizure types, like, for example, a sensation of spinning or even being turned upside down. And so it's only when the seizure spreads through the whole of the brain that people get these big generalized convulsions. But actually,
Yeah.
seizures really give us an enormous amount of information about what different parts of the brain do in terms of their function.
Yeah. That's amazing. I had no idea about all that. That's crazy. So the ones the seizure, the classic seizure that people think of when they hear the word, that's like the culmination. That's the worst kind of seizure then, is it?
Yes, that's when the electrical activity has spread throughout the brain and the whole brain is discharging in a very disorganized fashion, and you lose consciousness, you have no awareness, you shake violently, and those are the seizures that are most risky in terms of your health.
Yeah. And is there much like that can be done with epilepsy? I don't think there's a cure for that, is there?
There are some patients for which there is a cure. So, for example, if your epilepsy is related to a scar on your brain, a congenital abnormality, something that's been there since birth, or a tumor, then actually you can, for selected patients, you can undertake surgery to try and remove that potential trigger. For the majority of patients, we tend to use drugs, medications, and actually in about 60 to 70%, people go into what we would term seizure remission. So they stop having seizures completely with the first drug that we use.
Wow.
There is a proportion, about a third of patients in whom that's not quite so straightforward. And that is the bulk of the work that we do, is trying to get people to as close to seizure remission as possible.
Yeah. That's amazing. So is epilepsy one of the main sleep disorders that you specialize in, right?
So epilepsy is not a sleep disorder.
Okay.
Epilepsy is entirely separate, but there is a significant overlap between epilepsy and sleep disorders. So
Right.
we tend to use the same tools to study both. We tend to rely heavily on a tool called the EEG, which is when we stick electrodes onto the scalp and record underlying brain waves. We also, when it comes to sleep disorders, a lot of the strange things that people do at night
Mm.
may represent seizures. And so a significant proportion of sleep work surrounds discriminating seizures from, for example, sleepwalking or acting out your dreams, or a whole range of other sleep disorders.
Yeah.
And there is also a significant overlap between sleep and epilepsy, in that we know that if people with epilepsy have disruption of their sleep, their seizure frequency will often worsen. They'll often be much more difficult to control in terms of their epilepsy. And so historically, a lot of doctors who've been interested in epilepsy have also been interested in sleep disorders as well.
Yeah. Because I imagine everything comes back to sleep in a way. Everything medical, physical and mental comes back to sleep.
Yes, absolutely. There's a lot from a physical and psychological health perspective that relates to sleep. And it's not that surprising given that we should be sleeping a third of our lives, 8 hours a day. And so it's hard to imagine that something that, we are so evolutionarily programmed to do for a third of our lives, it's almost impossible that it has no bearing on pretty much every aspect of our waking lives.
Yeah. So what are the main sleep disorders then? Because you said epilepsy is not one. So what are the main sleep disorders that you specialize in where you work now?
So where I work at the moment is the Sleep Disorder Centre at Guy's Hospital, which is the largest sleep service in the UK. We see somewhere in the region of about 15,000 individuals a year. And we have our sleep laboratory, which is where we bring in patients to study their sleep, has 10 bedrooms. So every night we do 10 sleep studies. The bulk of those individuals have conditions that either cause them to be more sleepy than they should be during the day. So conditions like, for example, sleep apnea, which is where people stop breathing at night and that disrupts their sleep, or Restless Leg Syndrome, which is a neurological disorder that disrupts sleep, or conditions like, for example, narcolepsy or related conditions like narcolepsy. There are some rarer conditions like idiopathic hypersomnia and a condition called Klein-Levin syndrome, which people may have heard of because it's a very unusual condition whereby people become completely sleepy and exhibit behavioral change for a few days at a time and are completely normal in between. Right. And then the other kinds of patients that I very frequently see are people who are acting out their dreams or are sleepwalking or, undertaking very unusual behaviors at night.
Yeah.
Actually, the commonest sleep disorder is probably insomnia. Yeah. But we tend not to see standard insomnia. We tend not to see people with, very simple insomnia, for want of a better terminology, because those kinds of people should probably be treated in primary care. They should be treated at the GP level. Yeah. And very few of those people tend to come in for a sleep study.
Yeah, it's not so specialist, I suppose, on the basic level. But yeah, I definitely want to come back to insomnia and just general, obviously it links into all sleeping habits and how we sleep these days. But to go into a few more of those disorders. So sleep apnea, can you tell me a bit more about that and just what it is really, exactly?
So sleep apnea is firstly extremely common. It's a condition that affects roughly about 10% of adult males, about 5% of adult females. It is part of the spectrum of what we would term sleep disordered breathing. So sleep disordered breathing at its most basic level is snoring. And pretty much most adults will at some point in their lives snore. The reason why we snore is related to changes to the structure of our airway. So basically between our mouth and our lungs as we go to sleep. Now, some of that is related to whether or not we have our mouths open or closed, whether or not we have enlarged tonsils or have a very fat neck, for example. But it is also related to the fact that when we sleep, our muscles tend to become a bit more relaxed. Mm-hmm. And there are an array of muscles in our airway that maintain a degree of rigidity to that airway. So when we drift off to sleep, the airway becomes a bit looser, it becomes a bit slacker. And then when we breathe in, it vibrates because the walls of the airway are not very rigid, and that's what generates snoring.
Right.
But if your airway is particularly narrowed, if, for example, you have a small jaw, which puts you at risk of having a narrowed airway, if you're very overweight and fat is being deposited in the muscles of your airway, indeed around the outside of your neck, then that airway can become so narrowed when it becomes less rigid as a result of sleep that it actually collapses in on itself. And when it collapses in on itself, it means that you stop breathing for a brief period at night. Now, when you stop breathing, of course, your brain says, oh, oxygen levels are going down. I'm having to work really, really hard to try and keep breathing. And you partially wake up. And that cycle can recur again and again and again overnight with significant consequences. So typically, the people that I will see who have sleep apnea will stop breathing roughly between 15 times an hour, and the worst I've seen is probably 120 times an hour. So and you can imagine that when that happens throughout the night, that's going to absolutely, firstly, devastate your sleep, but will also have some important consequences on other aspects of your health as well.
Yeah, that's insane. So twice a minute, that's crazy. And so you don't feel like you've woken up. You wouldn't be conscious of being awake, or would you? How would that work?
So it's very variable. Some people really don't have any idea that they've sort of woken up repeatedly. Other people will be aware of the fact that they will sometimes wake up with a sensation of choking or gasping. But for the most part, people will kind of say, oh, I didn't sleep very well. And then they will wake up feeling completely unrefreshed and will often be very, very sleepy indeed during the day. And sleep apnea certainly is a significant cause of, for example, road traffic accidents, people falling asleep behind the wheel of a car. And so regardless of all the sort of health issues, crashing into a brick wall is not very good for your health either. So simply the fact of having disrupted sleep is potentially very hazardous for you.
I mean, that's crazy. That reminds me of something I heard yesterday while I was looking into a few things to do with sleep. Daylight savings time. I do want to come back to these disorders in just 1 second, but yeah, daylight savings time. I heard that when we lose that hour, I don't know if this is UK or worldwide or where, I think it might just be America, but when we lose that hour, like I've heard heart attacks go up by 24%. And then when it's the reverse, when we get the hour back, they go down by 24%. Have you ever heard that?
So I'm not sure about the figure of 24%. You may well be right, but certainly
I'm quoting somebody else.
Yeah,
so.
Yeah. I mean, we
don't quote me.
we know that sleep restriction or sleep deprivation is quite a stressful thing. It's and I don't mean stressful as in psychologically stressful. I mean physically stressful. So, for example, if you're sleep deprived, your levels of cortisol, a steroid that your adrenal glands produce in response to stress, goes up. And we know that levels of adrenaline and noradrenaline go up. And all of these things are not particularly good for your blood pressure. They're not particularly good for your heart. And this is at least one of the explanations for why chronic sleep deprivation or sleep restriction is associated with increased risk of heart disease, increased risk of high blood pressure. And certainly on a single night, if you extrapolate that across the entire population, then it's quite likely that actually having more sleep deprivation as a result of losing an hour's sleep is going to have some impact on the number of individuals who have had an MI on any particular night.
Yeah. It's just mind-blowing to think that even that 1 hour on one day can have that effect, even if it's not what I just said, even if that percentage is not correct or whatever, even if it's much smaller, it's amazing to think that just 1 hour on an anomalous day can have such far-reaching implication.
I mean, you're extrapolating it across a population of 70 million or so perhaps it's not as surprising when you think of it in those terms. So, for each individual person, losing an hour's sleep is not really going to significantly increase your risk of having a heart attack. But if you extrapolate it across a whole population, it just suggests that, well, it shows you how important sleep is for various aspects of your health.
And where it takes me is that, if everybody's losing that 1 hour and then we see, like you say, over a grander number of people, we see the effect. I just imagine how many people lose sleep just generally every week, just hour here and there, 2 hours here and there, or a bad night there. And there must be a lot of health problems that are completely down, or not completely, but are largely down or partly down to lack of sleep or bad sleep habit, which it's big to think about it, isn't it?
I guess that some of the difficulties that researchers have, there's a lot of research now that illustrates the importance of sleep for heart health, for brain health. So things like cognition, like dementia, risk of even things like asthma attacks. One of the major difficulties in terms of proving a causal association. So what I mean by that is that proving that, if you have insomnia, or if you're sleeping 5 hours rather than 7 hours, that is the direct cause of the poor health outcomes, relies on you to be able to track sleep on a long-term basis accurately, because a lot of these studies are reliant on people saying, on average, I sleep 5 or 6 hours, on average, I sleep 7 or 8 hours. And if there's one thing that I've learned over the decades of being involved in clinical sleep, is that we're very poor witnesses to our own sleep. And so people will say, oh, I slept 3 hours, whereas actually we've clearly recorded them having slept 8 hours, for example. And so we are reliant on, I wouldn't put it quite in these terms, but, there's this concept of garbage in, garbage out in computer terms. If we don't have a sensible, accurate measure of how much sleep people are actually getting, then it's very difficult then to correlate it in a causal way to health out. But certainly we've got plenty of evidence to suggest that that is indeed the case.
Yeah, that's amazing. To jump back to apnea, sleep apnea, I think you said it was 10% of men and 5% of women have it in the UK. I'm assuming, tell me if I'm wrong, but I'm assuming over half of those numbers probably don't know they have it.
Yeah, I think
or
that's
at
very
least
good.
a chunk.
I think there's very good evidence to suggest that actually it's much more than half. So we probably are only diagnosing the tip of the iceberg, in that, probably more like 15% to 20% of individuals who've got sleep apnea know that they've got sleep apnea.
Yeah. So a lot of people that are just, chronically tired and just always never feel rested, it could well be sleep apnea. Yeah.
Absolutely.
So, tell me about narcolepsy as well. That's where you fall asleep. It's not just this, I'm sure, but it's where the one that's known for is falling asleep in completely inopportune moments, right?
Yes, that's absolutely right. So narcolepsy is a very pure neurological disorder. So it is entirely related to the loss of a really tiny number of nerve cells in the brain that produce a particular chemical. The chemical is called hypercretin or orexin. And that chemical is fundamentally important in stabilizing sleep and stabilizing, so that basically it promotes wakefulness. And when you are asleep, it promotes non-dreaming sleep. So individuals with narcolepsy, they do get these sleep attacks, as you have alluded to. So they will often fall asleep at inopportune times. I've had patients who, for example, have fallen asleep whilst they've been standing in goal in a football match, or even more stimulating situations. But actually, they also, in addition to the marked sleepiness, they also get other phenomena. So because they tend to go into dreaming sleep directly from wake, sometimes they'll often hallucinate as they go off to sleep. So they'll often see things in the room, or experience or hear things, for example, in the room as they drift off to sleep. They'll often experience something called sleep paralysis, which is when you, as you're drifting off to sleep or when you wake up, you suddenly feel like you're completely paralyzed and you can't move.
Yeah.
And what that really represents is, so paralysis, muscle paralysis, is a normal phenomenon when it comes to dreaming sleep. But for most of us, we're not awake whilst we're in that aspect of dreaming sleep. Whereas if you're flicking in and out of, in between wake and dreaming sleep, then you may experience that paralysis whilst you're awake.
Yeah.
And then the other final very common thing that people with narcolepsy get is a condition called cataplexy. Cataplexy is when they suddenly lose control over their muscles, usually in response to strong emotion. So, for example, if they laugh, or if they get very excited or scared, they will lose muscle strength and will often collapse to the floor, which, as you can imagine, is really quite debilitating. It's potentially life-changing.
Yeah, definitely. How rare is that one, narcolepsy?
So narcolepsy affects about 1 in 2,000 of the population. So
much more rare than apnea, for example.
It's much rarer than apnea, but the likelihood in it is that in a large school or in a university, for example, there will be at least one or two individuals with narcolepsy, probably a significant number more.
Yeah.
And it is a condition that often comes on in teenage years. So actually 15 or 16 is the peak age of onset for narcolepsy. And once you have it, it's a lifelong condition, because once those nerve cells are damaged, they're gone forever.
Yeah. And I suppose the people falling is like when you have this, like you mentioned, the guy in goal, the goalkeeper. I'm assuming there's not this sensation where he's like, oh, I'm really tired now, I might just have a lie down. I'm assuming it just hits you and almost like you just pass out. But how does that work?
Well, I think that's certainly the case for some individuals. So there are these discrete sleep attacks whereby, 1 minute they are awake, the next minute they're fast asleep without any control. For some individuals, it tends to be a little bit more gradual, and they tend to be excessively sleepy throughout the day, and will typically, if they are sitting down for more than a minute or two, they will be asleep, but it won't be quite as dramatic as those sort of sleep attacks on the football pitch, for example.
Yeah. Okay. So during that, you talked about sleep paralysis, which can affect people with narcolepsy, but that can be a standalone thing as well, right? I mean, I've had that a few times when I was younger. I haven't had it for years now, thankfully, because it's horrible. But I remember when I was younger, maybe a teenager or young adult, I'd wake up and just completely unable to move, and I'm in my own head and I'm freaking out, and I never had it with the hallucinations, because I know that can be a thing as well.
Yeah.
I just stuck there. And I remember the sensation of the first time is obviously the worst, because you have no idea. And then I remember when you kind of gradually you figure it out a little bit. And I remember trying to convince either my little finger or my little toe to make a little movement. And then once you get that tiny movement, just kind of moving more fingers, more toes, and then you're out of it, you snapped out. But just tell me more about that, because ever since I was affected by it a little bit, and it was only a little bit, but it's fascinated me and terrified me at the same time.
So I've only ever had sleep paralysis once, and that was when I flew back from Australia and was incredibly jet lagged. Right. And even knowing what it was, I knew exactly what it was. I knew what I was experiencing. I knew what I had to do. It was still a very unpleasant experience.
Yeah.
So you're absolutely right. It is important to stress that sleep paralysis is something that some people will occasionally experience. And as I said, it is this. So many of the sleep disorders that we see really represent an overlap between the different stages of sleep. So, for example, sleepwalking represents an overlap between very deep sleep and wakefulness. People acting out their dreams at night similarly represent an overlap between REM sleep, dreaming sleep, and wakefulness. And sleep paralysis really is another illustration of this, because what it shows is that there are aspects of your brain or areas of your brain that remain in dreaming sleep, and aspects or different areas of your brain that are awake. Now, in sleep paralysis, it's really only the bits of your brain that are responsible for generating the paralysis that is the characteristic feature of REM sleep that remain on whilst you're fully awake. And so it is that sort of essentially the bleeding in of the motor aspects of your dreaming sleep into wakefulness that result in REM sleep. So anything that disrupts your REM sleep is going to predispose you to sleep paralysis. So typically things like sleep deprivation or irregular sleep patterns, which is why sleep paralysis is often seen in students, for example, because they're drinking until late at night and doing other things. And seems to be sort of relatively rarer in other groups. But there are some other potential causes, like, for example, anxiety, which seems to destabilize REM sleep. Certain medications, drugs like benzodiazepines, which increase muscle relaxation. So there are a number of potential causes, and it is seen sometimes in people who are otherwise entirely normal. So in and of itself, it's not a marker of any underlying disease.
Yeah. It's a weird thing, isn't it? That it can be involved, like because of a disease, or it can just turn up one day. Just you just can't move when you wake up, just completely out of the blue. Yeah, it's not very fun.
There are so many weird things related to sleep. So, and this is a good example, but it's one of many.
Yeah, I bet. I'm sure we'll get onto a few more today. Um, you mentioned sleepwalking, but before we talk about that, which I'm just again fascinated by all that kind of thing. Restless leg, again, something I have a little bit, and I know people that get this. My nan's always saying that she's struggling with it, and in fact I said to her, I was speaking to somebody about sleep today, and she said, oh, ask him about, my restless leg and stuff. So restless leg, again, how common is it, and what can you actually do about it? I read something about like putting corks in your bed. I'm assuming that has no scientific backing to it, but
I believe the technical term is bollocks, but
yeah,
restless leg syndrome is a neurological disorder. It is, once again, very, very common. People, many doctors have no understanding of it and don't, may not have even heard of it, but actually it is incredibly common. It affects up to probably about 1 in 20 individuals, to a variable extent. So in this neurological disorder, people typically complain of an urge to move, and it's usually the legs, but not invariably so. And that urge to move is often accompanied with some unpleasant sensations. So an aching or a tingling or a buzzing, or occasionally people complain of pain or insects under the skin. And when they move, then it gives them a little bit of relief from those sensations. Now, the problem is that one of the other aspects of restless leg syndrome is that it's under circadian control, by which I mean that it tends to come on in the evening and at night time, which is exactly the time when you want to try and be keeping still to try and get off to sleep.
Yeah.
And when you keep still, that sensation, that urge to move, and those unpleasant sensations tend to build and build and build, so that people with RLS often have great difficulty getting off to sleep. And the other unfortunate aspect to this is that it's often related to frequent leg kicking or twitching once you are asleep, which also disrupts your sleep once you are asleep. So it's a sort of double whammy. You can't get off to sleep, and then even once you've got off to sleep, you might have some difficulty staying asleep.
Is there anything that can be done, like on an individual basis, like people to try and minimize it or stop it, or when it's happening? Is there anything you can do?
So there are a number of different reasons why people might have restless leg syndrome. As you described, many people with RLS have got a family history of RLS, and there have been a number of genes that have been identified that increase your susceptibility to it. So for many people, it is primarily genetic, but it can also be related to other conditions. So iron deficiency is a very common precipitant of restless leg syndrome. There are certain drugs that we know are very good at precipitating RLS, and pregnancy is another very common cause. Now, part of that is related to iron, because iron stores go down when you're pregnant. Some of it is hormonal as well. So the first step is really to try and understand why you might have RLS, and to see whether or not any of those underlying causes are readily reversible in you.
Yeah.
The other thing that you can do is we know that alcohol, nicotine, caffeine, all of those can exacerbate RLS. And if that's the case for you, then obviously there's something very clear that you can do about it. Yeah. And actually, for the majority of individuals, they can get away either with trying to reverse the underlying cause, or they can do other things like, for example, gentle exercise before bed, massages, stretching, a whole range of other things that can provide some relief. In the minority, however, in about 15% of people with RLS, they do need treatment, and there are a number of different drug-based treatments that we can prescribe. They're all prescription only, to try and help them get a better night's sleep.
So yeah, come and see you if you've got it really bad.
Well, at least start with your GP, because your GP might be able to sort you out.
Yeah. Okay. Let's go on to something a bit weirder. Let's talk a little bit about sleepwalking. And like you said, you mentioned acting out your dreams. That was something I wanted to mention to you. Like, I've never had it extreme, but I've had that kind of, say, for example, let's go back to your goalkeeper. Say I'm in goal in my dream completely randomly, and somebody takes a shot. I can sometimes feel my arm wanting to move or something to try and catch it. Maybe when I'm half asleep, that's more then. But I'm sure that it's very... well, it's not a very good example. I'm sure it happens in a much grander scale for a lot of people. But talk to me about those different phenomena.
So we tend to call these kinds of behaviors, so unwanted behaviors or abnormal behaviors at night, we term them parasomnias.
Okay.
And we tend to divide them into parasomnias arising from REM sleep, rapid eye movement sleep, which is the stage of sleep that we typically associate with dreaming, and a non-REM sleep, so essentially deep sleep. So, and they are intrinsically different, both in terms of what happens, what people's experiences are, but also in terms of their significance. So if people are acting out their dreams at night, so these are dreams of a narrative structure that are characteristic of REM sleep, a plot evolving in your mind's eye, a story like a film evolving, and you are physically acting out your dreams, often these are violent dreams, then that is something termed REM sleep behavior disorder. So as we've already said, in REM sleep, you're typically paralyzed, but for some individuals, that circuitry that generates that paralysis doesn't work properly. And so people act out their dreams. And we used to think of that as being what's termed idiopathic essentially meaning that we don't know what the cause is, we don't know what it's associated with. But what we've begun to understand over the last few years is that actually there are a whole range of neurological disorders that often present with REM sleep behavior disorder years before the frank symptoms of those neurological disorders are present. Conditions like Parkinson's disease, for example,
right,
or dementia, a type of dementia called Lewy body dementia. And so people, particularly if you're in your 60s and 70s and you begin acting out your dreams at night, it's really important to make sure that you at least have a discussion with somebody, because that might be an early sign that something is a little bit amiss in terms of your neurological health.
right.
Some drugs can do it. It can be associated with other conditions like narcolepsy. So, I really don't want people to sort of go away thinking, oh, if I act out my dreams at night, then I must have Parkinson's disease. That's not the case at all. Now, when people experience REM sleep behavior disorder, they will recall their dreams. So they will recall having a fight or playing football and kicking out and doing other things. But what they won't typically do is they won't get out of bed, they won't look around the room, they won't interact with what's going on around the room. And that's in stark contrast to the non-REM parasomnias. So these are behaviors that arise from very, very deep sleep. And that's what we would class sleepwalking as. So in non-REM parasomnias, people can do some very, very complex things. They can interact in a very meaningful way with their environment. So, for example, I've seen individuals who have, ridden a motorbike or driven a car in their sleep. I've seen people who've rewired, household electrical gadgets in their sleep, painting, cooking, eating. Some of the other things that people do are, for example, night terrors. So they'll be very, very scared and fearful and will be worried that something, tremendously awful is going to happen to them. Sleep talking, those kinds of things. So in these behaviors, non-REM parasomnias, people will often have their eyes open. They will often interact with their environment. They will, you may even be able to have a conversation with them. The conversation might not make entire sense, but you will be able to interact with somebody in a non-REM parasomnia. Now, the reason why this is very important is, apart from the fact that people get out of bed in non-REM parasomnias and can do some really odd things, unlike REM sleep behavior disorder, is that non-REM parasomnia is not associated with any other neurological disorders. In that, it's very common for children to sleepwalk or to sleep talk. This is almost part of the realm of normal. What's interesting about these kinds of conditions is what they tell us about the functioning of the brain, because we know that what happens in these kinds of disorders is that actually there are parts of the brain that remain in very deep sleep. And those parts of the brain are typically the frontal lobes, which are really where our judgment, where our consciousness, where our reasoning is based. Other parts of the brain that remain asleep typically are an area of the brain called the hippocampus, which is where memories are formed. which explains why for many people, when they sleepwalk or have a night terror or do one of these odd things, they often have no recollection whatsoever. But actually, the parts of the brain that are responsible for movement or for emotion or for reward, like the reward that you get from eating or from sex or whatever, demonstrate waking behavior. And so this really illustrates the fact that actually the brain has this ability to be awake and asleep at the same time. It's one of those other overlap conditions, but I guess in non-REM parasomnias, it's much more overt, much more dramatic an illustration of that fact.
Yeah, that is fascinating. In the non-REM, that is truly fascinating. Like, I can't really get my head around it. When I was young, I used to think the idea of, people sleepwalk, they'd have their eyes closed, they're walking around bumping into things. But the idea even of just the basic idea of somebody sleepwalking with their eyes open and, like you say, interacting with the environment, that's amazing. So I don't know how does that work?
So I guess the way to think of it is, sleepwalking perhaps is not the right term for it. These are a range of behaviors, and they are a spectrum of from being completely asleep to being completely awake. So the way that I tend to think about it is, for example, the person who can drive in their sleep is probably largely awake. The majority of their brain is wide awake, but actually there's probably only one or two parts of the brain that are still in some sort of sleep hangover state, the bit of their brain that's responsible for memory, and to some extent the bit of the brain that's responsible for rational thinking, because clearly driving up and down a road at 3 o'clock in the morning is not entirely rational, but actually by and large they're probably almost entirely awake, whereas somebody who's just mumbling a few words in their sleep is probably largely asleep. So that's why sleepwalking is perhaps not the best term, because you're neither fully asleep and you're neither fully awake.
Yeah, I see what you're saying. I mean, how would the decision process be, like, while you're half asleep? Say for the person that wants to go or doesn't want to, I'm using the wrong language already, but the person that ends up going and driving the motorbike or the car in the middle of the night while they're a certain percentage asleep. Yeah, how would the brain, how does it decide to do this or that, or is it just completely random, unknown?
Yeah, I don't think we know. It's look, the way that I tend to think about these kinds of phenomena is that they are very similar to somebody who's had a serious head injury or somebody who's just had a seizure. Part of the brain is working very normally, part of the brain is not working normally. This is a pathological state, and how you behave, the choices that you make, whether or not how sensible those choices are, very much relate to which part of the brain is not working properly, how extensive the parts of the brain that are not working properly are, and of course in somebody who's sleepwalking, that can vary from one event to another as well, depending on how awake they are or how asleep they are. So it's highly variable.
Yeah. And do people, would they be much more likely to have a crash, for example, if they're driving like while half asleep, or does your brain, I don't know, make it safe? It's very confusing.
Yeah, I think you probably are more likely to have a crash. Look, there's not been that many documented cases of people driving in their sleep.
Yeah, I'm using an extreme example.
Yeah. So, but certainly, for example, people who are maneuvering around a strange environment are more likely to bump into furniture, for example. So clearly, people are not acting entirely as they would do when they are fully awake. But people can do some pretty complicated things.
Yeah. And can that kind of just happen out of the blue? Can somebody that's never had any issues with sleep, can one day you just do this, like wake up in your sleep and walk around? And
it can do. It's quite unusual for somebody to do that, having never done anything, particularly in their childhood. The typical situation that we see that in is, for example, in individuals who have taken sleeping tablets for the first time. And there are some sleeping tablets that dramatically increase your risk of non-REM parasomnia. So I saw somebody a little while ago who had never had any sleepwalking events, and then she was prescribed some sleeping tablets by her GP and would regularly wake up in the middle of the night in her bath full of bubbles up to her chin and would have no idea how she got there. So, and then when she stopped taking the medication, things settled down again. So,
Yeah.
so that's the typical situation that we see it coming on very much later on in life.
It must be terrifying in those situations for the person affected by it. It's crazy. What are some of the, I mean, I'm sure you've already said it, the motorbike and some things like that. What are some of the craziest or most extreme examples that you've dealt with? Can you talk about any of your former patients? I think you wrote about some of them in your Nocturnal Brain, right?
Yes,
you
yeah.
talked about some case studies.
So certainly some of the more dramatic cases are cases that I've written about previously, like the woman who rode her motorbike and drove her car. We see a fair number of individuals who've injured themselves really quite dramatically. So, for example, jumping out of a second or third story window and fracturing, their limbs.
Yeah.
The other person that I once again wrote about in the Nocturnal Brain was a patient of mine who eats voraciously at night to such an extent that he wakes up every morning feeling completely nauseated because he's so overfull. He will eat a block of lard. He will, on some occasions he's tried to empty his kitchen out of all edible substances and has woken up in the morning to find that he's kind of found his parrot's bird seed and has poured salad dressing over the bird seed and been eating that at night. So, and there are many case reports of individuals who have eaten stuff that is either toxic or very hazardous, raw meat or drunk, bottles of chemicals. The most extreme, there are individuals who have committed crimes whilst they've been allegedly sleepwalking. So there are a few famous cases of people committing homicide whilst allegedly sleepwalking. And I've got a patient who was convicted of rape whilst likely having had a non-REM parasomnia, actually.
Wow, that's intense stuff. How did that kind of thing? I mean, I'm sure you don't want to talk about that specific case, but those kind of things, how would that get proven and how would that get decided with those?
Well,
sort of things?
I think it's a very difficult area of forensic medicine. Because unless you are there on the night in question with electrodes attached to your scalp, it would be very difficult to be definitive. But certainly one can make some degree of judgment based upon what has happened, what the circumstances were, what the defendant and the alleged victim say happened. But it's very, very difficult. It's a very grey area.
Yeah. Is it true or is it a common misconception that it's dangerous to wake somebody that's sleepwalking, like while they're in a place that's different from where they fell asleep? That's a classic thing in the movies, right? There's always the thing that happens.
So for most people, it's not dangerous at all. The reason why I think that view has come about is that certainly if somebody's in the midst of a sleepwalking event and you violently try and shake them to try and wake them up, then it is theoretically possible for them to become violent in return because they are obviously confused. They don't quite understand what's going on. And that can lead to either injury of the person or injury of yourself. And so the best thing is to sort of gently guide them back to bed. They'll typically go back to sleep again and wake up in the morning none the wiser that anything has happened.
Yeah. Okay. Well, I'm glad we put that myth to bed. I didn't even mean that pun. That was a genuine accident. I can't even apologise for it because it was a genuine accident.
I thought you were being very quick-witted there for a second. So.
I wish. No, afraid not.
You should have just claimed it.
Your reaction made me think I should just own up because I was like, oh, he's not impressed. He's heard that one before. No. Let's talk a bit about insomnia. One of the most, like you say, one of the most common sleep disorders and something that I'm sure affects lots of people, and probably the percentage of people affected is going up year on year, I would imagine, with the kind of lifestyles we live these days. Just talk to me a bit about it and a bit about how our lifestyle does affect it.
So insomnia is perhaps the commonest of all sleep disorders. So about 30% of adults in any one year will experience a an episode of insomnia. But about 10% of the adult population will have what we term chronic insomnia. So this is difficulty getting off to sleep or staying asleep for the majority of nights for more than a 3-month period. That's how it's defined medically.
Right.
So it's incredibly common, and it's very distressing for many people. Being awake, having difficulty getting off to sleep while everybody around you is asleep, can be a very lonely experience, and people often get very distressed by the fact that they know that if they don't get a decent night's sleep, they're going to feel horrible the next day. That in itself increases people's anxiety around sleep, and sometimes actually drives the insomnia. So we think that there are some very important psychological changes that occur in insomnia that are then supplemented by some physical changes as well. So typically, from a psychological perspective, there's that anxiety that I just talked about, that the fact that you kind of get frustrated or anxious about the fact that you can't sleep, and that is going to be a problem for you the following day. You try and fixate on the process of going off to sleep, but of course, as soon as you try and make sleep an active process, it's impossible. Sleep is a
I've
passive
experienced
process.
that exact thing you're explaining right now. Yeah.
So and then people also then develop some anxiety related to bed. So they will, for example, find themselves drifting off to sleep on the sofa, and then they go up to bed, and as soon as they go up to bed, they kind of feel that mind is racing, that they feel very, very agitated, and that's something that we term hypervigilance or hyperarousal.
Okay.
But there are also some unconscious psychological factors, because of course we all associate particular environments, particular stimuli in our environment with particular behaviors. It's a bit like sort of walking into a dining room and seeing a table laid out beautifully. You start feeling hungry because you associate seeing the knife and fork, the plates, everything else with the act of eating. In the same sort of way, on a subconscious level, we associate bed with sleep, unless that association, that pattern of conditioning, that conditioned response has been replaced by associating bed with a place where you struggle to get off to sleep, or where you try to get off to sleep rather than actually drifting off to sleep. And so there are a whole range of conscious and unconscious factors that seem to drive insomnia, that generation of that abnormal link to sleep that people have. If you've had sleep deprivation for a prolonged period of time, then there are also some chemical changes that occur within your body, all of which then drive insomnia. And then people get into a slightly vicious cycle whereby the psychological factors drive the physical factors, which drive the insomnia, which strengthen the psychological factors, and so on.
Yeah.
And so people can find themselves in a very deep and dark place.
Yeah. And so tell me, what's the kind of, is there like in measuring it in hours or minutes or whatever, what is insomnia? Where's the boundary, the cutoff?
It's a good question. There is no cutoff, and that relates to the fact that, as I said earlier, we're very poor witnesses to our own sleep. So there seems to be a very poor correlation between what we can objectively measure on sleep studies and people's experience of sleep. And when we talk about insomnia, we are largely talking about their experience, their own personal experience of sleep. So, now some of that relates to the fact that much of our experience of sleep is psychologically driven, but some of it also relates to the fact that actually when we measure sleep, we use those scalp electrodes that I was talking about, and that tells us about what's happening on the surface of the brain. It doesn't necessarily tell us what's happening deep down in the brain. Okay. And so it gives us a relatively limited snapshot of sleep. So it is quite possible for somebody to sleep 7 hours based upon the EEG evidence that we have, but actually to wake up feeling completely exhausted and feeling like they've slept very, very little indeed. And it may simply be that there is a small part of their brain that's responsible for awareness that actually is awake, that we can't measure using the scalp electrodes.
Right.
And in fact, there is some evidence now to suggest that there are particular changes when we use more detailed methods of measuring brain activity that suggest that these individuals who have what we would term, or historically was termed, sleep state misperception, now we would call it something called paradoxical insomnia, actually do have some brain changes that undoubtedly influence their experience of sleep at night.
Yeah.
So in answer to your specific question, is there a cutoff? No, the cutoff is really about whether or not there is a complaint of difficulty getting off to sleep, staying asleep, and feeling unrefreshed with daytime consequences.
Yeah. Is there much advice in terms of staying asleep and obviously getting to sleep? I mean, I'm sure you've got bags of it, and I'm sure a lot of it relates to light and screens, which I'd like to ask you about as well. But in terms of general advice for, just getting to sleep and staying asleep.
Yeah, so actually this has really been very clearly formalized now in a treatment that is widely available. It's a treatment called cognitive behavioral therapy for insomnia, so CBTI for short. And we have very good evidence that CBTI now is the optimal treatment for insomnia. What CBTI does is it uses a number of different strategies. So some of it is about sleep education, so trying to correct people's misperceptions of what a normal night's sleep is, what sufficient sleep is, some relaxation techniques, using something called stimulus control, so essentially trying to reprogram the brain to associate your sleeping environment with sleep and nothing else, and then using your brain's own mechanisms by making you slightly more sleep deprived to actually drive you into sleep a little bit more easily. And this CBTI program is now very widely available on the NHS. It can be accessed digitally, so through a sort of avatar-based system, which works very, very well for the majority of individuals, or it can be delivered via local psychology services as well. And this is really the gold standard first-line treatment for insomnia nowadays.
Wow. Okay. Can you get access to that directly online, or do you need to go through a GP or a doctor first?
You need to go through you can pay for it, but if you go to your NHS GP, you can get it prescribed for free as an NHS patient. Okay,
cool. Tell me more about screens, and I mean lights are not such a thing, not quite as interesting as screens. The fact we're so addicted to them now, like everybody. In fact, pretty much every guest that I've had so far on this podcast, I think at some point or another we've come to the topic of like screens, social media, phones, that kind of thing. So both in terms of screens and social media, I know they're different, but they are related. Yeah. Can you talk about the overall impact of that and on sleep?
So one of the main mechanisms by which sleep is driven is through a chemical called melatonin, which is produced by a small gland in our brains. And melatonin secretion is very sensitive to exposure to bright light, particularly light that is rich in the blue part of the spectrum. So we know that if you expose people to bright light in the evening, that can suppress your natural production of melatonin and can have an impact on your sleep. So the concern is that when you use gadgets at night, and a lot of these LCD screens, iPads, other tablets, phones are quite rich in blue light. The concern is that that's suppressing your natural melatonin and is actually giving rise to a poorer quality of sleep. Now, it's not quite so straightforward as that, in that actually the intensity of blue light that comes out of these screens is relatively low. If you're using it for long enough, so typically sort of an hour and a half every night, then it will certainly potentially give rise to a resetting of your body clock, because melatonin is also fundamentally important in terms of regulating your circadian clock. So it will drive you to want to go to sleep later and wake up later. But there is the separate issue that if you are, particularly over the whole sort of, we've been through one disaster after another in terms of news cycle, Brexit, COVID. Before that there was, I'm sure there was something else. So looking at social media before you go to bed is not particularly calming for your mind. It's not particularly conducive to being relaxed and getting into a state where you're ready to go to sleep. And so there is this sort of whole other aspect to the use of gadgets, which is that actually they are quite alerting, regardless of their influence directly on your sleep. They're not very conducive to a good night's sleep.
Yeah. And I would say it's even, you can go further as well. Like if somebody's, notifications, so you're going to send a message or you're going to do something, and then I can imagine people are waiting there to hear that pop. And me personally, if I have my phone next to me at night, it's always on airplane mode or whatever, night mode. And I know I shouldn't have it next to me, but I do sometimes. But either way, like I say, it's shut off. But I know a lot of people do have it on and actually on, so it will make the noise at night. And that must be so unsettling to kind of, even if you're not hearing it every night, to be kind of half expecting or half waiting for, am I going to hear that? Because we're constantly thinking of our phones and where's our phone and what am I waiting for? Emails, text,
So my recent discovery, which I wish I'd have known about several years ago, was obviously, every so often I'm on call for the week for Neurology. Mm-hmm. And so I have to have my phone on and next to my bed in case I get a phone call in the middle of the night. But, invariably I'd find that some email or some, WhatsApp would come through in the middle of the night and irritate me. So I, to my embarrassment, it's only recently that I realized that you can filter out of these notifications between certain hours. And now after between 10 and 7, I don't get any notifications at all. The only thing that comes through is a phone call, which has changed my life.
I didn't actually know you could do that, so I might have to check that out as well.
Okay.
Could be quite good.
So if there's one thing that people take away from this podcast, that might be it then.
Check out how your notifications work on your phone.
Yeah.
Let me just one quick question before we get on to, I want to ask you a bit more about sleep in general, how much we should get and that kind of thing. But one thing that happens, I know quite often to me and quite often to my girlfriend, I know it's probably very common, is you're kind of drifting off to sleep and you're lying in your pillow, your eyes are closed, you're half asleep, and then boom, you wake up, you're falling or something's happened and you got that sudden wake up where you feel your heart beating and you feel like, a bit of a fright, and then back to sleep again. But what is that and how common is that and why does that happen?
So the answer to what these are is something called hypnic jerks. So these are very common. They are a variant of normal. Do we know what causes them? Well, not really. We think that they originate in the brainstem, and it seems to be the case that as you drift off to sleep, sometimes the brainstem is very intrinsic to switching on and switching off, regulating sleep. And we think that what may happen is at the point at which you're drifting off to sleep, sometimes these areas of the brain that mediate these jerks actually are switched on, and you get what's termed a myoclonic jerk, this sort of sudden whole body jerk, sometimes the physical jerk, but sometimes the inner sensation of it. But we don't really fully understand why. Now, there are some interesting theories as to what these jerks may represent. So some people have said that they represent something called the Moro reflex. I'm not sure if you've ever heard of that. So
I haven't actually.
So Moro reflex is when you get a baby and a baby is kind of placed rapidly on their back, they will often jerk, their arms and legs will spread out in a sort of exaggerated startle response.
Right.
And this is a normal phenomenon that we tend to grow out of within the first few months of life. But it's thought that this may actually be a evolutionary mechanism that related to when we were apes and we were in trees, in that if you were falling, then it would make sense to suddenly spread your arms and legs out wide in order to try and break your fall. And so what it has been suggested, although we have absolutely no evidence for this whatsoever, that actually the hypnic jerk and the Moro reflex both have an evolutionary basis in this phenomenon to try and stop us from hurting ourselves when we fall out of trees.
Wow. Yeah.
Now, who knows if that's true or not? It's a nice theory.
Yeah, I like it. Yeah, tell me the optimum sleep, the optimum amount of sleep, the optimum conditions for it, or anything you want to say about optimum sleep.
Well, I think there are two ways to answer that question. So we can talk about what the optimum sleep is from a sort of population basis. And we have, very good evidence that, for example, when one looks at health outcomes, and the worst possible health outcome is mortality, either you're dead or you're not. So it's not a gray area. We know that if you sleep roughly less than about 7 hours, your risk of mortality goes up. If you sleep more than about 9 hours, your risk of mortality goes up as well. Of course, it's not quite so simple as that, because there are reasons why, for example, you might sleep more. That might also put you at increased risk of mortality. So, for example, if you've got multiple health issues, you're on a whole pile of drugs that make you drowsy, that might cause you to sleep more. And to a lesser extent, that's probably true for sleeping too little as well. For example, if you've got, health issues, and you've got pain, or you've got bladder issues or whatever, then you may sleep slightly less than normal. But certainly, there is a suggestion that outside of those hours of sort of 7 to 9 hours, that's potentially not good for you. But what we also know is that your sleep requirement is to a large extent genetically predetermined. There are genes that influence how much sleep you actually need. And those genes, those genetic associations have been demonstrated in multiple populations. And so to some extent, your sleep requirement is based in your genes. I have, some 1 or 2 families in whom everybody in that family only needs 4 or 5 hours of night sleep, and there is no obvious harm from that.
Right.
And equally, there are some individuals who are what we term genetically long sleepers, who need at least 9 hours in order to feel fully refreshed.
Yeah.
So the other way to answer that question, apart from, well, you need somewhere between 7 and 9 hours, which is probably quite unsatisfactory for most people because they want an absolute figure, is to say, well, if you're going to bed and waking up at roughly the same time every day, you're not lying in for more than an hour when given the opportunity, like, for example, at weekends. You wake up feeling generally refreshed, and then you're ready for bed at the same time the following day, then that suggests that you've probably got enough sleep for you. If any of those are not the case, then either you've got a sleep disorder, or you've got insomnia, or you're burning the candle at both ends, and you have what is euphemistically termed behaviorally induced insufficient sleep syndrome. You're basically sleep deprived because you're out partying or working too hard.
Yeah, my nan always used to warn me about that. So, yeah. What would you say is better in terms of alarm versus no alarm? And I know there's no necessarily a right answer, but what would be better for the body, like health-wise?
Well, I mean, I think that the answer to that is likely to be no alarm, because that suggests that your body is waking up naturally at a time that it's appropriate for it, rather than having a time forced upon it. And, a lot of people who have pretty good sleep patterns will often say that they will wake up just before their alarm, because their brain is very regulated to waking up at a particular time, and that's obviously ideal.
Yeah, that's definitely the ideal scenario. And what about like waking up with the sun versus like blackout blinds? Is again, so in the summer, obviously the sun rises a lot earlier. People might not be able to go to bed a lot earlier because of the nature of, you've got responsibilities. What would be better in that situation? Is it better to have the blackout blinds, but then you wake up and it's pitch black and you might be a bit confused? So
I think the everybody is different, I think, is the first thing to say.
Yeah.
But I think the second thing to say is, if you can't go to sleep in keeping with nature, then to expect yourself to wake up in keeping with nature is unrealistic. So it's all very well saying, oh, I get up at dawn, but if you haven't gone to bed until 1 or 2 o'clock in the morning because you've been, I don't know, playing Fortnite or whatever kids do these days, and or surfing the internet, then it's just not realistic.
Yeah. I mean, that's another one, is at night, especially in cities, right, developed cities, the amount of light pollution. I don't know whether that's something that comes up, whether it's noted, or I was just thinking about it yesterday. It must be, in my opinion, a big problem, an ever increasing one. Because even with curtains, you get a lot of light that can come through from street lights and just general from the city, that orange kind of glow.
Yeah. Well, for some people, it is a problem. If you've got a tendency towards insomnia anyway, then anything in your environment that is not, desperately conducive to sleep might worsen the quality of your sleep. For other people, it will make very little difference whatsoever. So if you're one of those individuals in whom ambient light does, you notice that there's an association with that your light levels and how good a quality night you get, then absolutely invest in a pair of blackout blinds. I think on that, in that vein, it's really important to stress something really important, which is that, you know, we doctors talk a lot about this concept of sleep hygiene. So sleep hygiene is a terrible term, but it essentially describes, you know, the behaviors and the environment that you're sleeping in that are all conducive to good sleep. You know, simple things like, you know, not having 10 pints before you go to bed, not having a cigarette just before you go into bed, making sure that you know your environment is dark and is the you know the right temperature, etc., etc. People who have insomnia can get very obsessed about sleep hygiene, but it's really important to stress that actually, you know, somebody who's a really good sleeper will not put out blackout blinds up in their bedroom, will not necessarily worry whether or not they've had a coffee at 2 p.m. or 4 p.m.
Yeah.
You know, it's all in relation to your own sleep and understanding your own sleep, rather than obsessing about the minutiae of what you've read in a list of, you know, sleep hygiene rules.
Yeah, because you kind of alluded to it earlier, but yeah, overthinking can worsen the problem.
This is my big issue with sleep trackers, in that sleep trackers, you know, the people who use sleep trackers tend to be enriched for people who've got issues with their sleep, who are concerned about their sleep, who are anxious about their sleep. You know, I've previously written about sleep trackers being the sort of the quantum physics of health, in that it's a bit like Schrodinger's cat. The very act of measuring sleep can influence sleep itself, because it makes you obsessed about the output of your sleep tracker. And by the way, you know, sleep trackers are highly variable in terms of their accuracy. So you may be being obsessed by the output of your sleep tracker, which is complete garbage anyway. And it makes you more anxious about the sleep that you are or aren't getting, and can actually make your sleep much worse. So it's a similar sort of phenomenon whereby, you know, the obsessional measuring of sleep or focusing on the behaviors around sleep can actually make sleep much worse.
Yeah, I can definitely imagine that. I used one for a little bit, the one on the Apple, the iPhone, and I couldn't really, you know, I didn't really get on board with it very well. It just wasn't for me. But are they accurate at all, or are they just a waste of time?
I think that they are accurate with regard to some measures of sleep. So they're reasonably accurate at telling you how much time you've spent in bed.
Like rest, I suppose. Rest tracker.
They are increasingly now, the latest iterations are perhaps a little bit more accurate when it comes to, you know, for example, whether or not you've been awake in the middle of the night. They are less accurate when it comes to sleep stages.
Yeah.
And the other issue is, of course, is that sleep stages are rather meaningless because they're very difficult to interpret. So, you know, the kind of situation that I see is people coming in with reams of sleep tracking data and saying, look, you know, my sleep tracker tells me that I'm getting, you know, 10 minutes of REM sleep every night. And you know, the discussion that I have is, well, first of all, you know, what your sleep tracker is telling you and what's actually happening may well have no bearing at all. And secondly, we don't even know what the significance of, you know, even if you were getting 10 minutes of REM sleep every night, we don't really fully understand what the significance of that is, and if indeed there is any significance to it.
Right. Okay. Yeah, that makes sense. Another one that's been playing on my mind to ask you, because this is something that most people would like to do, right? A lie-in on the weekend, yeah? So most people, they work the 9 to 5, or these days 8 to 6 or 6:30 job, 5 days a week. On the weekend, you've got, like you say, kids or whatever else. So maybe you get one day where you're allowed a lie-in of, let's say, 2 hours compared to your normal wake-up time.
Yeah.
Is it more beneficial to the body to not have that and just to continue doing your normal go to sleep and wake up? Or because again, you may be going to stay up a little bit later because it's a weekend, and you know, people aren't robots, so they are going to do that. Where do you stand between taking that extra few hours lie in versus just carrying on?
So I think,
and again, on a one day.
So I think the issue is not really whether or not you have that sort of lie in or not. It's really what it's telling you about your typical sleep patterns. Because if you are needing a lie-in, at the weekend, it probably tells you that you're, particularly if it's more than about an hour or so, it probably tells you you're not getting enough sleep for you during the week.
Yeah.
And so that is more the significance of having a long lie in. Along that vein, it's also important to understand that if you are significantly sleep deprived during the week, by having a lie in for as much as you want, actually, on 2 mornings of the weekend, you will not repay your sleep debt if you're sufficiently sleep deprived. So you will always be going in on Monday morning with still carrying some sleep debt, either in terms of how sleepy you feel, or actually, and perhaps this is more important, the cognitive deficits that you carry associated with that sleep debt. So to think that it's okay to sleep for 5 or 6 hours a night at the weekend, but it's during the week, but it's fine to catch up at the weekends, it is not quite accurate, because you're not catching up.
And talk to me more about that sleep debt, because I've heard that concept before, and so you can basically never catch up on sleep. Is that the long and short of it?
You can, but it takes much longer than you think it does. So, for example, when we bring in people for sleep studies, so say, for example, we're trying to work out whether or not somebody is sleepy because they're a bit sleep deprived, or whether they've got, narcolepsy, for example. And by the way, sleep deprivation can, in some individuals, look rather similar to narcolepsy. It can give rather similar results on the sleep study. Then we will typically say, look, we will track your sleep for 2 weeks before the sleep study, and we will track your sleep for 2 weeks before the sleep study, just to ensure that you're not sleep deprived, because 2 weeks is how long it can take to repay a sleep debt if you've been really sleep deprived for a long period of time. Okay.
And how do you repay it then? Do you have to just get like much longer sleep every night, or
not much longer? The other thing that is important to point out is that when you are sleep deprived, your brain is actually quite adaptable. So if you're very sleep deprived, your brain will actually prioritize, for example, slow wave sleep, deep sleep, what we term stage 3 sleep, over other stages of sleep.
Yeah.
And so it's not a direct, I guess a zero-sum game whereby if you lose an hour a night sleep compared to what you should be getting, that has the consequence of losing 1 in 8 hours of your sleep, because actually what happens is your brain then tends to boost the amount of stage 3 sleep that it's getting in and it sacrifices some of the lighter or an intermediate sleep that it's getting. So it's very difficult to be definitive about the degree of sleep deprivation that is important and how much catch up you need. If you are sleep deprived by an hour every night for 3 nights, you are not going to need to sleep an extra 3 hours over the following night in order to repay that sleep debt. It's not a sort of 1-to-1 ratio.
Yeah, you just maybe kind of turn the alarm off when at your first opportunity and let your body sleep it out a little bit.
Yeah.
Okay, cool. Nightmares. Can we jump in there quickly? That's again strong. Like your book is to do with that as well. Yeah.
Mm-hmm.
So, how? Why?
So nightmares, essentially unpleasant, vivid dreams. So we know that, first of all, it's normal to have nightmares every so often. It's people who have regular disturbing nightmares may often have something that is disrupting their REM sleep. So, for example, sleep apnea.
Right.
Or may have increased likelihood of psychological issues like anxiety or depression. There is another cohort of individuals who have recurrent nightmares, and these are those individuals who have, for example, post-traumatic stress disorder. So they've experienced something deeply psychologically traumatic, and that episode recurs in their dream mentation, in their dream imagery again and again and again. And it's out of this that some of the theories surrounding why we dream have come about. So there is some evidence that one of the functions of dreaming is to take memories with very strong emotional contexts, and try and down-regulate to remove, to cleanse some of the emotional context from those memories. Because it's good to remember that something terrible happened to you when X and Y and Z happened, in order that you can avoid it again. But if it's got a very, very strong emotional context to it, then what you don't want is, if that situation were to arise again, that you would be paralyzed with fear, for example. So the theory is that one of the reasons why people with PTSD have recurrent nightmares is because essentially when you're having that dream, it's the process of removing the emotion from that dream content. But because for you, when you have PTSD, the emotional content is so high that you actually wake up from this nightmare that you're having, and so that process is never completed, and the emotions are never down regulated from that dream. So it's a bit like a sort of playing the same song on a gramophone again and again, but before it reaches the end of the song, the needle jumps out of the groove. That song is never completed. And so this is, we think, perhaps why some individuals have these recurrent nightmares associated with PTSD.
Wow. So it's like it's your brain subconsciously trying to give you self-therapy, but not quite finishing the thing when you wake up and are like, oh, I had a nightmare. So maybe when you kind of sleep through it and you have, oh, I think I had a nightmare last night, maybe that was a good one that did make some progress.
Yeah.
Wow. Okay, cool. And how common are nightmares? I don't get many nightmares.
Yeah, I think that they are pretty common, actually. A lot of people do complain of nightmares. There are many people who actually, frankly, when you speak to them, their dreams are not necessarily particularly horrifying or unpleasant. But the fact that they have very vivid dreams every night, they find very distressing indeed. Sometimes it's related to the fact that they kind of feel that they're not rested as a result of their very, very vivid dreaming. So there's real, the spectrum of human experience of sleep is very, very broad indeed.
Yeah. You mentioned stress, anxiety, PTSD. Just talk to me briefly again about the relationship there with those things. I know they're all different, but they are related, those things, and sleep. Because I imagine we have touched on it a few times already, but I'm sure it has so many different interactions and correlations and things like that.
Yeah, the relationship between sleep and psychological health or mental health is complicated, and it's bi-directional. So what I mean by that is that sleep affects mental health, but mental health also affects sleep. So when you are depressed, then the typical sort of what we learned at medical school was that with depression there are some biological features, and early morning waking is often a feature of depression. Actually, there are some individuals who are depressed who are actually more sleepy than they otherwise should be. So it's not the rule for everybody.
Yeah.
Anxiety, obviously, if you're in a state of heightened alertness, hypervigilance, then that can make getting off to sleep or staying asleep very, very difficult. And so anxiety is often associated with insomnia. In fact, about 50% of people with insomnia will have anxiety or depression.
Yeah.
But the relationship also goes in the other direction. So we know that if you have very poor quality sleep, if you have insomnia, if you're sleep deprived, then that can worsen anxiety levels.
Yeah.
It can worsen your mood. It's increases suicidality or risk of suicide. If you have depression and you've got insomnia, it can make treatment of that depression much more difficult without at least addressing the insomnia alongside it. So clearly it's not a one-way street. It's that these entities, sleep and mental health, have a complex and intimate relationship.
Yeah. And I would say physical health as well, right, is in that same mix with the three-pronged kind of whirlwind of just chaos and this vicious cycle where it can each one affects the other one. And like you said, your sleep gets worse, so your mental health gets worse, which can then in turn affect your physical health and the other way around.
So there are very clear associations between sleep and obesity, between sleep and diabetes, high blood pressure, risk of stroke, risk of heart disease, cognitive decline, dementia, cancer, a whole gamut of physical issues. From my own practice, I know that if I see a patient with migraine, then actually sleep disturbance is often a significant contributor, or it can sometimes be the trigger for migraine. If I'm having difficulty controlling my patient's seizures, then sometimes sleep can be at the core of that. So there are many aspects of health, really, in all spheres. I mean, even when it comes to, for example, recovery from surgery, wound healing, the list goes on and on in terms of what influence sleep has on physical health.
It's basically the bedrock of everything, isn't it? In terms of all of our health and just life itself as we know it, it all comes back to, sleep.
Yeah.
Yeah, it's amazing. You mentioned dementia. Can you, again, just really briefly, can you just tell me a bit about, can it be caused by bad sleep? Can it be brought on by bad sleep? Obviously a longer period of time.
So this is an area of much attention at the moment from a research perspective.
Yeah.
We certainly, limited sleep opportunity or insomnia are associated with dementia. And there is growing evidence that relationship is causal, although it's not definitive. So what I mean by that is that actually it's the sleep disturbance, the sleep restriction that might be contributing to dementia. Now, this is complicated by the fact that we know that many neurological disorders often have a prodrome, a precursor state that results in other symptoms. And it may be that actually insomnia is actually part of the precursor to conditions like dementia. It may also be, and certainly there's been a lot of attention on this recently, that the drugs that are used to treat insomnia may somehow give rise to cognitive decline or dementia.
Yeah.
But there is some rationale as to why sleep may give rise to dementia, in that we know that within the brain there is a system called the glymphatic system, which essentially drains fluid from the brain. And within that fluid, there's a whole range of metabolites, of breakdown products of the brain being awake and alert, including the protein that is at the heart of what is thought to cause Alzheimer's disease. So when you are asleep, particularly when you're in deep sleep, those channels open up by about 60% and increase the clearance of all these substances from the brain. So if you are sleep deprived, if you're getting less slow wave sleep, less deep sleep than you should be, then actually we do see that even a night of sleep deprivation causes fundamental changes to the levels of these kinds of chemicals in your brain.
Yeah.
What we still have to prove is that is the mechanism by which sleep deprivation causes Alzheimer's disease or cognitive decline.
Right.
And there's a lot of effort going on to try and understand that relationship a little better.
Yeah, I bet. Because that's terrifying. Dementia is a terrifying thing, and if it's going to be brought on by sleep, I need to have extra focus on my sleep.
so at the current level of evidence, I would say that there is a significant chance that if you are significantly sleep deprived on a long-term basis, then that is potentially a reversible factor that might increase your risk of Alzheimer's disease. Do I think that one should obsessively try and rectify one's sleep in order to prevent Alzheimer's disease? I don't think we're there yet.
Yeah. Would you say that's the same for dementia? You kind of can categorize them together in that sense?
Yeah, well, Alzheimer's disease is probably the commonest cause of dementia. Yeah.
Right. Okay.
Yeah. So and there are other types of dementia, but Alzheimer's is the commonest.
Okay.
Now, there remains some debate as to insomnia, because insomnia and sleep deprivation are not the same thing. As I've already said, your brain does adapt in insomnia, and there are many people who have insomnia who actually, if you actually measure their sleep properly, they're not getting much less sleep than normal individuals. It's just that their experience of sleep is poorer. And we think that probably those individuals are not really at any increased risk of anything compared to the normal population. But for example, people who regularly sleep sort of 2 or 3 hours, it's quite likely that they have a similar risk to those individuals who are burning the candle at both ends.
Yeah. You mentioned earlier some people can do that, like sleep for 4 or 5 hours and be okay. Yeah. Is it like 3 hours? Is that, some of these like billionaires out there sleep for they say they sleep for 3 or 4 hours and they get up and they got energy. Is that possible? Is that like a genetic anomaly? What's going on there?
Well, I think these genetically short sleepers are incredibly rare. Very, very rare.
And I lucky.
Think that, lucky, although the few people that I've met have found it quite boring because they're awake when everybody else is asleep. I think for the vast majority of people, there's definitely been historically there's been a sort of slight moralizing about sleep, either and it's swung definitely from one end of the pendulum to the other, which is, originally it was like sleep is for the weak. Sleep, if you're a successful, banker or entrepreneur, you don't sleep, and if you do, then that suggests it's a sign of weakness. There, of course, is the other end of the spectrum now, which is, oh well, I only eat chia seeds and quinoa, and my body is a temple, and I make sure that I sleep 9 hours a night because this is how I keep my body pure. I think both of those ends of the spectrum are idiotic.
I think in corporate, like especially in corporate London, in lots of these, sales and things like that, I think it's still very much a culture to be like, it's a badge of honor. I only need to sleep for 5 hours and I can get up and I'm fine. Why are you so tired? And you're supposed to be in the super early and leaving late. And if you're not, then you're kind of frowned at. And I think that's, it's a big thing still. We are kind of, I think, gradually working away from that, but it's still very present.
I think that's absolutely right.
You think we need to move away from that?
I think we do, and I think that some of the big corporates are now beginning to understand that actually that attitude is first of all not improving the productivity of their staff, and is causing people to leave as well. And it'd be interesting to see what happens with the vast majority of people working from home, because I think it will be tied up with different patterns of working.
Yeah. I worked in a job in London where you're literally expected to be in not long after 7, and you're supposed to be there way before the official start time, and you're supposed to stay later than your official finishing time, which is already late, and then like I say, that whole kind of bravado about I don't need to sleep that much, go on, you'll be all right, and just crack on and that kind of thing. But it is unhealthy. On a lighter topic, and one that we can kind of bring us towards the close of this, tell me about naps and napping. Is it good? Is it bad? We talked about optimum sleep. What's optimum napping?
So I think that the answer that I'm going to give you is rather similar to an answer that I've given you already, which is it depends why you're napping.
Yeah.
So there is very good evidence that napping is good for cognitive performance. It's very good for your blood pressure. It has many advantages. However, if you are finding that you have to nap on a regular basis and without it you can't function, then it probably suggests you're not sleeping enough at night. And so and if you're finding that you are sleeping 8 or 9 hours at night and still requiring a nap during the day, then it probably suggests that you've got a sleep disorder at night.
Right.
Because something is influencing the quality of your sleep.
Okay.
Now, in the newspapers, there's occasionally these stories that suggest, napping increases your risk of dementia or mortality or whatever. And I think that probably represents the fact that if you are having to nap for 2 hours a day, then it probably suggests that you have got sleep apnea, or you have got something else going on with your health, or you've got a neurological disorder that you're brewing dementia already, rather than the nap itself causing the problem.
Okay.
So if you like every so often having a nap in the afternoon and enjoy it, go for it. But if you need to take a nap every day, then it's just that either you're not getting enough sleep at night, or there is something disrupting your nighttime sleep. Yeah,
some underlying problem. So if you are one of the lucky people that manage to have, good nightly sleep, and you can put the occasional nap in, and feel even better from it, how long is a good nap? Because if you go too long, you kind of wake up and you feel like you're like the middle of the night, right?
Yeah. So what you want to try and avoid doing is having a nap and then waking up from very deep sleep.
Yeah.
And typically it takes about 30 minutes to get into very deep sleep. So we tend to say to people, look, if you're going to nap 15, 20 minutes, you'll wake up from stage 2 sleep, which will make you feel rather refreshed, but you won't have that sleep inertia or sluggishness that you get when you wake from stage 3 sleep. The alternative is to wait a little bit longer and have a nap of about 90 minutes, because by that time you should have gone through your first cycle of stage 3 sleep and should be in REM or lighter sleep again, which will make waking up a little bit easier. The other thing to consider is if you are going to get stage 3 sleep in your nap, then that is likely to make it a little bit more difficult for you to get off to sleep at night.
Yeah, that makes sense. Is there anything in these like really short naps? Some people have heard of them doing like a nap for a couple of minutes or less than 5 minutes to get this really.
Yeah, if you can do it, then in fact, that's what people with narcolepsy do. So in narcolepsy, we tend to say to people, look, we can give you all these drugs, and we do give people a lot of medication to try and keep them awake. But actually, a part of the treatment is that, what you're trying to do is you're trying to stop yourself falling asleep when you don't want to. So you have to try and maintain some control over your own life. And so many of my patients will, for example, every day at 11 o'clock or whenever, creep off into a room, or will occasionally even go to the loo and lock themselves in a cubicle and have a nap for 5 or 10 minutes, and that can be sometimes sufficient to stave off sleep for the next few hours. So this is something that can be really helpful if you can do it.
Wow. Okay. Yeah, I didn't know, because I've never been lucky enough to be able to fall asleep in that space of time anyway, or even 10, 15 minutes is quite hard. But I didn't know if they were actually beneficial, so it's interesting to know. Okay. Well, look, Guy, let's get to one last thing. So if there's any message, I'm assuming it's probably going to be about sleep, but no pressure for it to be about sleep. Any message at all that you want to send to anybody that's listening or watching this, whether it be in a couple of weeks or when they're watching it, in a couple of years on YouTube archives, anything you want to say?
I think the key thing is just to understand what sleep means to you, to try and understand your own relationship to sleep, and to try and optimize it without becoming overly obsessed with it.
Yeah.
Because I think that it's when you become overly obsessed with it that actually many of the problems start.
Yeah. So pay attention to it, but don't overthink it.
Exactly.
Exactly. Yeah. It's probably good advice for lots of things as well, there, actually. general life advice there.
Yeah.
So, Guy, look, this has been amazing. I've learned a lot, and I'm definitely going to pay a lot more attention to my sleeping myself, and hopefully that's going to improve.
Wonderful. So one person converted.
One, and I'll get some of my family on board. So there's a handful. We'll do that. No, I really appreciate it. Thank you again very much, and have a good one. Have a good sleep.
Good chat
tonight.
Good chatting to you, Ben. Sleep well.
Yeah, you too. Thanks,
Bye-bye.
Guy. Cheers, Guy. Take care. Bye. Thanks for listening to that conversation with Guy Leschziner. I hope you enjoyed it, and if you did, please follow us on Instagram and subscribe wherever you listened. If you want to follow Guy or buy his books, all the relevant links are in the description. Thank you, Guy, for your time and for sharing some of your expertise. Be nice, be happy, be cool.